lot of information from the studies. And you know you made it when you hit the headlines of the National Post. On September the 7th, critical patients underfed. It's a nice dietitian. That doesn't make you feel very good, but it's basic talks about the International Nutrition Survey, where they found, I think probably about 200 ICU sites, more than 50% of patients are being underfed in the first 2 weeks. So what I hope to do today is look at the effect of low muscle mass on outcome from critical illness, how the renal muscle changes in an ICU stay, the limitations of our usual treatment practices, challenges, perhaps what we can do about it, and just a brief look at the supplemental alternatives, what kind of holds the most promise. And also want to go through a case study of probably the most challenging patient that we have seen to date, and I will say how long that has been. When we look at the complications of loss of lean body mass, we start out with a normal muscle mass. Patient comes into the unit at 10% lean body mass with a 10% mortality rate impaired. Immunity increased infection probably the first step that was seen. 20% increased healing, weakness, infection, thinning of skin, all sorts of skin breakdown. 30% 2 weeks sit. Pneumonia is a usual effect of malnutrition. No filling, 50% mortality associated with 30% of lean body mass. At 40%, it is terminal, no going back. Death usually leads to pneumonia. This has been looked at several different patient populations, from World War II famine victims to more recently AIDS patients. There's a lot of work looking at body composition changes, and that 40% of lean body mass across the board. We're seeing 100% mortality. So we have the ability now, in incredible advances of body composition techniques in a clinical setting, so we can see what is actually happening in the ICU patient. Les Mosey and her group out of the University of Waterloo, which I'm happy to say is actually going to be coming to do some research on our patients, seeing what happens to them post-admission. They looked at 149 patients that elderly patients greater than 65 years of age at a level 1 trauma center who required an admission CT scan. So they were on admission. They quantified the muscle index using the third lung vertebrae that has been validated as representative of the mass. They categorized patients as sarcopenic or non-sarcopenic using sex-specific established muscle cut points. What they found is that 71% of on-admission of ICU patients were sarcopenic, independent of BMI. And when you look at BMI, only 9% of them were identified as underweight. So what they found is a significant increase in hospital mortality with sarcopenic patients, significant then 3 days on sarcopenic patients and ICU 3 days. And BMI was not predictive of survival, ventilator-free days, or ICU days. A similar study done in Holland with a younger group of ICU patients. It was a retrospective analysis of 240 ventilator patients who had an abdominal CT scan between admission day 1 and day 4. And it kind of shows the limitations, is that getting a CT scan just to see the muscle composition is not likely to happen, so they're kind of taking when the patients had them. Mean age 57 and mean BMI 25, just kind of hitting the obesity range, same lung vertebrae. And they had low muscle area in 63% of patients. So we're getting similar results. And looking at overall hospital mortality of the patient population, 29%. Low muscle area was 38.3 versus 12.7 normal. And the stepwise regression analysis showed muscle area was an independent predictor of mortality and not BMI. So a which kind of correlates with that as the muscle is better. Under that obesity paradox, there's been a number of studies and meta-analysis recently that have shown that lower hospital mortality in elderly patients with a higher BMI that is indicative of overweight or obesity. It's observed in chronic conditions as well, like renal failure requiring renal replacement therapy. This is in direct contrast to the International Nutrition Survey, which actually showed the opposite, that patients with greater BMIs had a higher risk of mortality, were more sensitive to lower caloric or protein eating. Whether that's due to muscle mass in these groups is a distinct possibility. That's why we're seeing the difference. There is higher muscle mass associated with higher BMIs. For example, healthy obese female, the fat free or lean body mass from BMI 25 to BMI 50 increases from 40 to 60 kilos. There is a significant increase in lean body mass for healthy obese patients. So when we look at what happens to skeletal muscle mass in an ICU stay, fairly obvious decrease in mass. If they're not fluid overloaded, that's pretty obvious. You can see at the end of the bed. Function and structure. The loss is huge and rapid, 1% per day. You also get muscle fiber atrophy. You get a change in the type of muscle fibers you have, which is going to affect function. You get an increase in muscle water and lipid content, so you have a muscle that may take up the same volume but has a significantly bigger composition. Initial limited responses to nutrition support. The question mark is there because when studies are looking at that, they may have to be scrutinized for the quantity of that nutrition support. Because how much did they get? We'll talk about that a little later. If you're not getting what you need, it's you can't say they're not fine. I wanted to throw that up. Visuals, this is what a CT scan will show you. What you're seeing here is changes in the muscle structure during an ICU stay. You get an increased fat deposition in the muscle fibers in between them. And we look at, there are two separate components, muscle mass versus function. Strength does not solely depend on mass, and the relationship between strength and mass is not linear. You can retain mass, but lose function, or retain function and lose mass. And what's to help the patient get off the ventilator? We don't know. It may drive, but it certainly may drive what we're looking for in terms of marking our responsiveness and how much nutrition support we need. As an aside, an increase in lean body mass was shown in studies with growth hormone, and I'm probably showing our age. I don't know if any people remember those studies. It was looking at growth hormone and muscle function. I see that had to stop because of an increased mortality with growth hormone. The improvement in function by driven respiratory muscle function is seen in absence of any changes in muscle mass. And that's classically what we look at is increasing muscle mass when perhaps we need to be looking at what is happening functionally or the form follow function. It's a lecture I remember very, very well from my early days. Dr. Gigi Boy, who's pioneering nutrition, exactly showed a lot of data that suggests form follows function. Functional improvement happens well before we're actually going to get changes in mass. So some of the other factors that contribute to all those changes, the neuroendocrine response to critical illness, we know that you have a significant increase in catabolic hormones, significant decrease in anabolic hormones, infection, sepsis, cytokine release, corticosteroids, critical illness lab, disease and nutrition. So if we're expecting a silver bullet, if we think nutrition is the answer, it's easy to see it's not going to be the total answer to this issue. So when we look at the scope of the problem, we have a very high percentage of patients entering the ICU who are already sarcopenic, who already will it's going to affect their outcome the minute it hit the door. We also know significant muscle loss happens usually in the first 2 weeks, and it's also going to affect your outcome despite our quote-unquote best efforts. And the research has certainly shown us you can't do an end-to-end assessment and say to pick these patients out. So what can we do about it? I like to think we're not just going to accept this is happening, there's not an appropriate answer. So when we look at the limitations of our usual treatment practices, achieving adequacy intake. Probably every major study that's been done on nutrition support in ICU in the last 5 years has failed to achieve adequacy intake. It's a huge problem. International Nutrition Survey, the redox study that everybody has such hope for. If you look at how much feed they actually got in or nutrition support, it's not near, I think, probably around 60 to 70%, which is 70% is actually a high number. How we determine requirements. The holes in how we do that are huge. From what weight we use when we try to determine protein, when we try to determine how many calories we need, if they're underweight, if they're obese, or what are we trying to get at in terms of how we determine those requirements. And when we specifically look at protein, it's always the minimum. When you look at the establishment of protein requirements, whether it be from the food requirements that are likely to be adults or when it's critical illness, it's always the minimum amount to achieve positive balance. There's not a lot of studies looking at what's the optimal amount. How much can we push this? And how much do we need? There is anabolic resistance. There's no doubt, even the hormonal environment, but if we push that protein intake, can we push past that resistance? Timing and method of nutrition support, redox and growth hormone, I mean, all of these studies have shown us that our PME can happen in the acute phase. Conflict with research results. How are we going to apply those practices? And how and when do we include the patient as a nutritional goal? You're not seeing that in medicine. They're always talking about the acute phase of critical illness. And looking at intake following extubation, post-ICU stay, is that impacting their hospital outcome? So just looking at a few of the prospective randomized control recently that have been comparing nutritional changes in ICU, if you look at them, look at the calorie intake, look at the protein intake. And if we look at most guidelines for protein intake in ICU, they say 1.5 to 2.0, maybe as low as 1.2 some people. 43 grams, 47 grams a day. That's not even close. Probably if you looked at the median weight, you're at 0.5 grams per kilo a day. The right to omega trial, which received a lot of press, looking trophic versus control, has some omega-3s in there, but control intake is actually 5 times higher. And interestingly enough, that particular trial, the control group, have the lowest mortality rate, or one of the lowest that has been reported in NPR's trial. The tight calorie control, again, we're approaching that, but we're still probably less than the 1 gram per kilo mark. The EPANIC trial, which we'll talk about a little bit later again, very actually the early group got little protein in the first few days. Doig study looking at early primary nutrition as well, very low. The Harvard study that was just published in October, the calorie study, I really hate it when they bury that kind of information in supplementary appendices. I actually couldn't find appendices. It's probably my default, but the comment in the study is that very few of the patients reach the target. So it's a huge issue. We can't achieve adequacy intake. We don't know what adequate nutritional support will do in terms of maintaining muscle mass. And then when we look to apply things looking at research results to clinical practice, there have been enormous amount of studies looking at trophic, looking at small amounts of feed versus full feeds, and the results are conflicting. You don't know. A lot of it is depending on how they're determining their requirements, because what adequate is differs from study to study. When you look at the study patient population versus clinical reality, the mechanic study, which looked at early critical nutrition versus late, the study population is not clinical reality. They were very short-stay patients that in a clinical family we would not even consider to give them TPN. Can only go on TPN for 3 to 5 days. Very low protein load, very high glucose load. And those of you who remember the administration study in 1921 showed exactly the same thing. Is that high glucose load, short-term TPN doesn't do a thing. We know that. That's not something that we apply to practice. Combination products and single nutrients. A lot of the studies differ very much, that whether they use just omega-3 fatty acids, for example, or they're using a whole battery of antioxidants, omega-3, higher protein, whey protein versus, so you can't extrapolate results one to another. Timing of support and intervention. That is huge. Like we do have some studies that are showing us perhaps we can't do much in the early phases of support, that you guys need to do your job before we can do our job, basically. That's what we're kind of looking at. Is that true? We really don't know, again, because we're not giving them adequate support most of the time. Nutritional status versus nutritional risk. A lot of the editorials, opinions, based on a lot of the conflicting studies, look at previously well-nourished patients. That is the majority of the study populations. Again, that's not in clinical reality. We've got 65 to 70% who are pre-existing malnutrition. They're coming in with a low protein mass. And they all say whether they should be treated differently is uncertain. So we don't know for 60 to 75% of our patients, none of these recommendations have been shown. And lack of information regarding post-ICU stay. And I would probably more appropriately say post-execution. Because the minute that YouTube comes out, we don't have a lot of information on what they're taking in. When does research become part of the plan? A lot of times, I mean, I had this discussion with residents not here, about not that long ago, is that so concerned about overeating, how that's going to impact on the respiratory function, how that's going to CO2 production, that has been paramount in terms of looking at nutrition support. Most of the research is centered around that acute period of critical illness while this muscle waste is going on. There's a huge lack of research and therefore recommendations on rehabilitation following acute critical illness. We have an extended ICU. That's where they go when their kind of acute illness has resolved. They're then dependent because there's been so much research going on. How many calories per protein does it take to build back muscle? I fall back to sports nutrition literature. That is really difficult to source out. You cannot find that. And you're actually looking at a healthy person versus a critically ill patient. We may have a bit of an advantage because a lot of the kind of max amount of supplements and proteins in athletes have a limited because they're already maxed out. They already have metabolic pathways are at max rate. Critically ill patients or are chronically critically ill patients are not. I love this quote. The period following critical illness is characterized by anabolism, remodeling, restoration, and redistribution of body composition. I put should be because that's what it should be. This is not possible without adequate nutritional delivery. I think, it's something that we tend to forget or minimize. We do spend an awful lot of time feeding the patients early, trying to get their full needs in, switching support when it's not working. But the minute that vent tube is gone, the feeding tube is out, taking a sip of ginger ale, we don't, there's a lot more attention paid on can they eat in terms of swallowing versus how much are they eating. And I don't know if I put the question to the room, do you know what the average calorie and protein intake is on a Fair Food diet? It's about 900 calories and 2 to 4 grams of protein. And stay on that for a few days. And if you look at the trouble we have had or muscle loss, if we manage to achieve any improvement, we're going to wipe it out fairly quickly if we take adequate support away. And when we look at the intake post-ICU stay or post-extubation, there's an incredible amount of factors that affect intake. Loss of appetite, early satiety. These patients that haven't been fed for a number of days to weeks will get early satiety, taste alterations, mealtime routines. We can't duplicate what they did at home. We cannot give them that variety of their preferences that they may need. Premature discontinuation of nutritional support. If the patient clearly states he doesn't want it, and there is a lot of patients who don't want to depend on artificial nutrition support. They're pulling the tube that they're saying, I don't want to swallow tube, is a far different scenario than patients who are accepting of the tube. It's really seen as a significant step in recovery. Psychological, from a family perspective, over brain. It is, I'm not suggesting it's easy to keep feeding tubes in a lot of patients, but it's something that needs to be considered. Just because they took a sip of ginger ale doesn't mean that they have the ability to eat what they need. There's one study that looks at intake post-ICU stay at the COO intake of critically ill patients post-extubation. It was a prospective observational study. 50 patients who presented at least 24 hours and leave ventilation for 5 days. And in our unit, that's not very long. That is not particularly long. They were advanced to an oral diet. They had no supplemental foods or parental nutrition. And 44% of them were malnourished by subject global assessment. When we look at the nutrient intake, never exceeded 55% across 7 days. Mean protein intake never exceeded 37 across the 7 days, and 75% of the study group never met more than 75% of their needs. We know that. We watch them. Whether the nurse at the bedside said, eat everything off the tray, he's doing great. That tray is probably not containing anywhere near what his caloric requirement is. I attended a conference in Europe, and it was interesting because what is fascinating is the whole 30-30, which has yet to be disputed, that 30 grams of protein, whether young or old, is what maximizes protein repletion and protein muscle growth. So I came back and took a look at our hospital menu and how much protein is given kind of per meal. There's not many meals that actually approach 30 grams. Another study looking at 116 patients who post critical illness, they looked at them 3 months following discharge. 50% of them had continued to lose weight, 70% of them had lost appetite, and 40% of them lost, 70% lost taste, and 40% lost appetite. So getting out of the hospital, they still, this continues. And this is actually what the group in Waterloo is hoping to do in our patient population. We're actually going to follow patients following extubation in the ICU, looking kind of that is behavioral, where there's skeletal muscle mass. Start there, how much they're eating and how much is changing after we extubate these patients. So when I turn to look at some supplemental alternatives, briefly what is in the literature, what holds the most promise. There's I will preface by saying there's not a lot of research, just kind of going through what is available, omega-3 oils, creatine, hydroxyapatite, and anabolic steroids.
You keep mentioning this study that's coming down the pipe tomorrow. Are you going to talk more about it specifically today? Or?
I'm not going to, only because I don't think I should.
Sure.
Basically,
Are you allowed to say how they're going to measure skeletal muscle?
Absolutely.
Ultrasound. Okay.
Ultrasound and
Sartorius muscle?
Yeah. Those coefficients you may find in disappearing.
Sure.
Okay, omega-3s. And then a lot in the literature, a lot in ICU. They build muscle as well. It's arisen from the fact that blunted anabolic response to nutritional stimuli, i.e. protein, is due to defects in signaling skeletal muscle. Specifically, the mTOR, P7S signaling pathway, which is probably the main point for anabolism. And this may be mediated by increased inflammatory activity, bearing on the fact that omega-3 fatty acids indeed may reduce inflammatory responses. They may be something to look at in terms of protein depletion. And there's stimulation concepts that both noted in animal studies. And this is interesting. There have been many ICU studies using omega-3s in different whether it be in a feed, whether it be as a supplement. None of those studies have actually looked at it in terms of muscle changes. In 2011, we have a study using 16 healthy adults greater than 65 years of age. Even in the sports literature, there is an increasing look at the elderly population because we know there is a natural increase in aging. They were given fatty acid supplementation for 8 weeks, either 3 grams of omega-3s or 3 grams of corn oil. What they found is the amount of muscle phospholipid omega-3 content doubled in omega-3 supplementation. There was no effect on basal protein metabolism, but there was a significant increase, a doubling of the anabolic response to amino acid and insulin infusion. And there was no effect of corn oil on either one of those things. Another study tried to take a little look on mechanism of action. 44 adults who were not engaged in consistent systemic exercise training, so your average sedentary person, got a 6-week treatment of 4 grams of fish oil or 4 grams of safflower oil. What they found in the fish oil group, greater fat loss, increased lean body mass, decreased salivary cortisol, which is felt to be one of the effects that omega-3 fatty acids will decrease cortisol. But there was no change in resting metabolic rate, which is just kind of interesting because the main determinant of resting metabolic rate is muscle. And if they got increased lean mass with no increase in metabolic rate. Creatine, another one from the sports journals. What is it? It's an organic acid that's synthesized by 3 amino acids, arginine, glycine, and methionine. Rationale for its use, what does it do? It increases the intracellular pool of creatine. Phosphocreatine increases ATP, so you should just get an increase in protein metabolism. There are greater than 350 trials in healthy persons performing exercise that shows improvements in strength, power, and fat-free mass. And probably the most pertinent study for an ICU population is that 40% of the effect is independent of physical training, which has some potential for our patients who do have limited motility. And there's been no safety issues noted. The International Society of Sports Nutrition, the last position statement they put out about creatine was in 2007, and they consider it to be the most effective nutritional supplement currently available to athletes for high-intensity exercise and lean body mass buildup. It's not only, they state with their review of the literature that it's not only safe but possibly beneficial in preventing injury or management of select medical conditions when taken within recommended guidelines. And it's been reported to have a number of potentially beneficial uses in the medical or clinical population, further research is warranted in these areas. The populations that have been studied, there's been some neuromuscular like Duchenne's, there's been a little bit of work in ALS, and the studies are certainly very, very small, but there have been none in the ICU patient population. HMB, hydroxymethylbutyrate, my personal favorite. It is a metabolite of leucine, which is an essential branch chain amino acid and has been shown probably to be the most potent regulator of protein turnover. Leucine has been shown to both decrease muscle catabolism and increase synthesis, and HMB is felt to be the compound that's responsible for those effects on protein turnover. And why not just leucine? Because it's much more efficient. 20 grams of leucine are required to provide 1 gram of HMB under normal physiological conditions. So why would we not just go with the HMB? Again, the International Society of Sports Nutrition put out a position statement in 2013 showing significant benefits. It can be used to enhance recovery by attenuating exercise-induced skeletal muscle damage in trained and untrained populations. And if we extrapolate to what I said earlier, that muscle damage, does it have a role in critical illness-induced muscle loss, muscle damage? It has been demonstrated to increase lean body mass and function in elderly sedentary populations. It also may result in greater declines in fat mass when used with exercise. It also, as I said, works both to inhibit catabolism and increase anabolism, and chronic consumption is both safe in a young and old population. Sounds perfect. There's been a few limited small ICU trials, and interestingly enough, what they've used as primary endpoints is not really what we're looking for. 100 ICU trauma patients had 3 arms. They had HMB and arginine, just HMB, or arginine and glutamine. There was decreased nitrogen excretion. They're looking at decreasing protein turnover in all of the HMB groups, but they did no measures of either lean body mass or functional strength. The other study, 34 mechanically ventilated COPD patients. They received 3 grams or placebo. Their primary endpoint was a decrease in inflammation. They did see decreased CRP levels, again, but did no muscle function, strength, or mass. Other patient populations, there are very inconsistent findings in looking at other populations. And I would just comment about those products, why we're not using them, why there's not more research. There's a hope of doing some research on HMB, but product availability is actually a huge issue to kind of get the clinical quality we need, the purity we need, having Health Canada sign off on it, and also a compound that's going to work down feeding tubes, because that is the majority of our patients, and that's how we're going to be doing them. Anabolic steroids, specifically oxandrolone. Anabolic steroids have certainly gotten bad press. They really have gotten bad press, and that's mainly from their misuse in athletic populations, which has tended to overshadow some of the potential clinical uses they have. In 2004, a review for drugs showed statistically significant improvements in body composition, recovery, muscle strength, function, in catabolic conditions. HIV-related muscle wasting is a huge population that's been studied with. Burns is another population. Neuromuscular disorders and alcoholic hepatitis. And the oxandrolone is preferable because it's an oral pill. It's not an injection. It has a very high anabolic to androgenic activity, and it's the one that has been used most in clinical settings. Now, there's very mixed results in critically ill patients. Timing is likely an issue. Again, we've learned that trying to
kind of reprioritize protein synthesis in the acute phase is not likely a good idea, and adequacy of support is going to be huge in those patients as well. None of these agents work on their own. They need to have substrate. If you're not giving in enough protein and calories, you're not going to see much of an effect. Okay, I just want to end off with our case study. It's in my years, many years, he's probably the most challenging, the most severely malnourished patient we have ever seen in our unit. We had a 58-year-old male who was repatriated to MSICU following a 5-month stay in another ICU. He actually lived in the area, which is why he is repatriated to us. He was admitted to hospital in June with pneumonia ARDS. His stay had been complicated by septic shock, acute kidney injury, bilateral pneumothoraces, and had a lot of gastrointestinal issues of diarrhea, distension, vomiting associated with enteral feeding. His only medical history is that he was HIV positive for 18 years on heart therapy and had a viral load of 0 when he hit the unit. On his initial hospital admission, what made kind of this patient nice for us is that we had a huge amount of history on this patient. We knew exactly what he'd been taken in. We knew what his kind of nutritional parameters were on admission, and we don't often get that luxury with patients. 170 centimeters, he weighed his pre-illness weight 58 kilos, BMI of 20.1. He was very active. He was a weightlifter. We actually saw pictures of him, and he had very defined muscles, higher than average muscle mass, and he used numerous supplements. He and his partner followed a naturopath very extensively and did use a lot of supplements as well. When he came to us 5 months later, he weighed 39.1 kilos, BMI of 13.5, so he had lost 32.5% of his muscle mass. So this was an easy one to see malnourished. Didn't have to go to the sarcopenic definitions. On transfer, he was on a renal formula giving him 2,260 calories and 122 grams of protein. The supplements he was on, some of them were provided by the patient, some of the hospital had provided. Glutamine, omega-3, taurine, carnitine, lipoic acid, coenzyme Q10, multivitamin, B12, selenium, pancreatic enzymes, and a probiotic. So a laundry list of supplements. So his admission parameters, his prealbumin was 0.12, doesn't mean much with a CRP of 296. His hand grip strength was very low, 9 to 10. For his age group, a male, the normal is about 55. Give or take. Subjective global assessment, clearly C, he's severely malnourished. I didn't need one lab parameter. He's one person you could look at the end of the bed and see that. His nitrogen excretion we do on our 24-hour urine was 20 grams a day, times 6.25 kind of gives you the minimum amount that needs to be for protein use. His measured energy expenditure, 2251 calories, which is very high. Like if you look at, he weighed 39 kilos, you do the math on that in terms of calories per kilo, he was very, very hypermetabolic. So we took a look at him, and I have to say we weren't very optimistic. He certainly had a very strong will to live. He was not ready for this to be the end of his life. So when we sat down as a team, we sat down with the patient and his partner. Our plan of care was a first primary focus on repletion, functional recovery, and wound healing. He did have a coccygeal ulcer at the time, which was very deep and not healing. Our goal for provision of calories was 130 to 150 of his measured energy expenditure. And that took me a lot of digging through a lot of old textbooks to say, how much do I need to replete this patient? Where am I looking at? If I just give him his measured, I need to go up and over if I'm going to have any chance of repleting. And protein to achieve a nitrogen balance of +3 to +5 grams per day. Aggressive physiotherapy program. If we don't get physio going, we're not going to maximize how much muscle or protein we can replete. And a big one was delay attempts of weaning from mechanical ventilation until nutritional improvement is seen. That was a big focus in the other hospital, a big focus for the patient. The partner just have to get off the ventilator, just have to get off the ventilator. But it was clear nutrition was impacting on his ability to do that. And oxandrolone therapy. We went with the oxandrolone therapy. We didn't wait to see if nutrition support was alone was going to have an effect, and that's basically because we had a 5-month history of what could be seriously considered anabolic resistance. They certainly had they did have some issues with getting enough in, getting the patient to tolerate it, but it seemed like nutrition support alone, and at the stage he was at, it didn't seem reasonable to wait to see what nutrition support was going to do, and certainly to rationalize those additional supplements. The partner is actually a research biochemist, so we weren't working with the average kind of healthcare consumer. It was a big discussion on how those supplements were going to be kind of rationalized and more taken under our care plan. So what did we give him? We gave him Oxypa. And if you know, that sounds kind of, that's a weird choice for this patient. It's mainly used in ARDS, and that had clearly resolved. We did need some Peptamen AF based on GI intolerance and issues. We chose the Oxypa, I will say, to be honest, was a lot of negotiation with the patient and his partner. It has a very high omega-3 acid. We knew the literature on that, so we felt that was important. We could get rid of the fish oil supplements that they were going to have, and this was basically a Hail Mary. We were going to pull out all the stops to try and start repleting this patient. The rate was adjusted according to his measured energy expenditure and his nitrogen balance as needed. He was a very difficult energy expenditure measurement, and I'm sure the RTs weren't all that happy with me because we did many times, we did it 24 hours. We did it around the clock 24 hours because they were very high. In fact, we really want to see, was that an isolated, because when we do measurements, they're only an hour, 2 hours, so we really wanted to see what the 24-hour expenditure was. He tolerated the feed really well for about a month. No emesis, no abdominal pain. Stools were about 300 to 500 cc's a day, which had been a chronic issue for him, likely drug-related. However, we initiated parenteral nutrition on day 32 because of refractory diarrhea, abdominal pain, and we actually needed it for 2 months. I didn't decrease the calorie intake to 105 to 125% of his ME because we know that TPN calories can have more adverse side effects than feeding enterally. We weren't at liberty to probably max out his calories. The protein did remain the same. The diarrhea, after many GI consults, scopes, felt to be secretory in nature due to basically the heart medication. Significant improvement with Pepto-Bismol, which is a recommended treatment for secretory diarrhea in AIDS patients. Full enteral support was resumed at admission day 93. The oxandrolone treatment was 10 milligrams twice a day, initiated day 5. We had mild elevations in liver function tests on initiation, but they increased significantly after we started the parenteral nutrition, likely the combination of the anabolic steroid plus the parenteral nutrition plus the heart therapy. So they were discontinued for that reason at 8 weeks. Okay, so when we look at what happened during his stay, he weighed 39.1 on admission. On discharge from hospital, he weighed 52.9, which is about 91% of his pre-illness body weight. BMI up to 18.3. Hand grip strength. And when you saw this patient, one of my consultants suggested I have him come in. If you were to see this patient today, I think it's a good example of form or function. He still looks very thin. He certainly has not achieved the muscle mass that he had previously, but his functional strength is much improved. We get updates from him, and that's what he says. His weight's about the same, but his strength improves on a weekly basis. He's still only about 40 to 60% of normal. His nitrogen losses, urea nitrogen decrease is what we would expect them to do if we're improving from an anabolic point of view. His prealbumin progressively improved, and his energy expenditure decreased. Now, if we're building more muscle mass, shouldn't it increase? But we're also resolving a lot of things that increase in terms of sepsis, like all of those other things that are increasing metabolic rate. And his disposition, he was transferred to the ward on admission day 124 and discharged from the hospital a week later. His oral intake progressed quicker than I have ever seen. After I told you about the other patients who take 250 calories, this guy had a strong motivation. He was up to greater than 100% of his energy and protein goals. He had a lot of supplemental shakes. His enteral fees were decreased prior to transfer to the ward. I mean, this guy, he actually ate over and above, and we set the targets pretty high. He has remained well and out of hospital for the last 20 months, with one exception. 2 months post-discharge, he came into the unit for pneumonia, and we all kind of went, uh-oh. You know, we really thought that here we go again, but he actually was only in the unit. I think he was vented for a couple of days and in the unit for about 4. And then home, and he's been home ever since. We do like to get the pictures of him, and he certainly, but I think it's more an example of that it can be done. What worked, you really can't tell. Would tincture of thyme and no anabolic steroids worked? Maybe. Was it the dose of omega-3s, which it's about 8 grams a liter, so he was getting a huge dose. Unclear, but I think given the state he was in, like I said, we were going to use everything we could. So concluding, I would, as many as 70% of ICU patients enter with low muscle mass, which will impact their outcome, and it's further compromised by significant muscle loss. There is a strong need for clinically applicable methods for identifying these high-risk patients and to monitor the response to nutrition. An end-of-the-bed assessment is not going to do when only 9% of them are going to be, basically, you will see that muscle loss. The optimal timing of and amount of nutrition support repletion remains unclear. Adequacy of intake following recovery from critical illness requires much more attention to determine outcome, and when we look at outcome studies of patients, particularly from a hospital mortality or hospital stay, that has to be taken into account. The use of supplements commonly used by athletes may be of benefit to our clinical population. Thank you. Did I hit something? I'm done. Any questions? Yeah. Again, you know, I don't know if I'm supposed to bring all these things out. We are in the process of getting a protocol together to look at HMB. Right now, the biggest stumbling block is getting a supply that works down the feeding tube, I should say. Thank you. That's nice. Yeah, that's what I was going to say. Yeah. Oh, you're welcome. The benefit of higher BMI, the benefit of increased calories. Yes, yeah, absolutely it is. Yeah, absolutely. Which, yeah, that's exactly right. Yeah. No, that's what my parents used to be big fans of the South Beach diet. Yes, I have failed as a dietitian. I have since told them, stop that. Because if you get ill, you need a little more bulk. Yes. Yeah. Yeah. Absolutely.
Just a question. You know, I noticed this around stuff we always talk about nutrition. I was often talk about nutrition. Say that we should be eating, but it's not what we should be eating our patients. Has anyone looked at, two things, has anyone looked at the nutritional intake start sort of needs at 10. And the other thing is, you look, the way, at least I assess patients that will have these going and have a rate going. Does anyone look at actually having a visual feedback or intensivist of this is the nutrition requirement for this patient, and this is what they actually see?
Mm-hmm.
Because
Again, yeah, no, actually,
a lot of, I was thinking, at least clinically, is that, you know, you have somebody who's not meeting targets
Yeah.
for systolic blood pressure right now or whatever, and we immediately make
Yeah.
Adjustments for that. I don't know if we do the same
Yeah.
for nutrition.
no, thank you, because very true. Oh, yes. The question is two questions. Number one, has there been any studies looking at the difference weekend versus weekday with dietitian involvement, with minimal on the weekend, and how feeds, are they delayed? Are they started at low rate for how long versus during the week? The answer to that is no, but I will say that the International Nutrition Survey has that data. That may actually be a good thing for one of their students to try and pull out, because it's done on a day-by-day basis. The second part of the question is, have anyone look at a visual on terms of intensivist tendency? Okay, we're feeding the patient, and don't always go past that. They're not looking at the rate, they're not looking at the adequacy. If there was a visual saying this is what he's getting, this is how much he needs. There's been kind of indirect work on that. There's Mehdi Berger, who works out of Switzerland, who's a very well-known nutrition research. They actually have one. They have a daily energy expenditure chart that goes up, so you can see what they're getting. Dating myself, I used to have bright orange sheets at the on the chart prior to the database that showed what they were getting in and what they're taking. I know McMaster uses a percentage of calories or calorie deficit that's actually on the flow sheet. So, and they actually, at the last international survey, were ranked in the top 5. So indirectly, I would say that definitely makes a difference. But, you know, I will say in rounds, well, let's see, he's gotten 200 calories for the last 6 days, but I think it is a very important point that perhaps having that visual would assist in that.
We're noting that international nutrition surveys.
Yes, thank you. Yeah, it's a huge effort by Darren Halen's group, and has given a lot of valuable information. I like to present it to the consultants and say, okay, we're not improving, we're middle of the pack. That's not where I like to be, but.
Other questions for Bill?
Uh-oh, sleeping or shocked? Mm-hmm. Yeah.
In commercial supplements, is there an issue with the quality?
Yes. Yeah, and there was, actually I have a colleague in Sault Ste. Marie who actually uses it a lot, had previously used it a lot. There was a Canadian manufacturer who's actually going to discontinue it this year, and there would have been no concerns about the quality of it. But now we're looking at, we have to source from the States, and yeah, they don't monitor quality very well.
So on that note, with athletic nutrition supplements, they're not drugs, so they're not regular.
Mm-hmm.
You really have no idea what you're buying, what's on the label. Is that the case with the supplements that we consider?
You mean
In the hospital?
in the hospital? No. See, they have to be Health Canada approved as well, and Health Canada, and actually that's sidebar, the issue with HMB, they approved the Canadian manufacturer, they approved one manufacturer in the States who no longer are making it, so we have to go through the process again.
Right, well, that's 2 o'clock, so thanks very much again, Joe.
Thanks.